Good afternoon. The Subcommittee on Regulatory Reform, Commercial, and Antitrust Law will come to order. Without objection, the Chair is authorized to declare recesses of the committee at any time. I don't foresee any because that was the last vote for the day. We welcome everyone to today's hearing on the state of competition in the pharmacy benefits manager and pharmacy marketplace. And I now recognize myself for my opening statement. When a patient visits a doctor who recommends and prescribes medication, the patient rarely receives the prescription drug directly from the doctor. Instead, the patient submits his prescription to a pharmacy, which then dispenses that ordered medicine. While this may appear to the patient as a relatively simple exchange, behind the scenes exists a complex system. Within this system is a variety of different players who engage in millions of interactions that influence the types of drugs that are available and the prices that patients pay for them. Two of the key players in this process are pharmacy, benefit managers, and pharmacies. Today's hearing will examine the state of competition in these two important markets. Pharmacy benefit managers, or known as PBMs, play an important role in the healthcare system. PBMs oversee and administer the prescription drug benefits for more than 247 million Americans, or approximately 95% of Americans who receive drug benefits. Through the management of these benefits, PBMs perform a number of varied services. They negotiate the prices of prescription drugs with manufacturers and wholesalers. PBMs design drug formalities that dictate the drugs that will be covered under a benefit plan and the cost-sharing portion the patient will bear for each drug. PBMs also negotiate with pharmacies to determine which pharmacies will participate in their networks, the fees that each pharmacy will receive for dispensing drugs, and the amount the pharmacy will be reimbursed for each drug. By virtue of their central position in the administration of prescription drug benefits, some would argue that PBMs have the ability to place downward pressure on the prices of drugs. PBMs also can achieve efficiencies that result in savings both to the ultimate patient and the payer of health benefits. Pharmacies also play a critical role in the delivery of medicine to Americans. In addition to purchasing prescription drugs, they typically are the entities that directly engage with the patients. As someone who represents a district with many rural communities, I know firsthand how important pharmacies, particularly independent pharmacies, are to their customers. Many times, these independent pharmacies develop meaningful relationships with their customers and provide essential assistance when dispensing their prescription drugs. Together with doctors, pharmacies are part of an integral team that ensures patients are receiving the proper drugs in the correct amounts and administered in the appropriate fashion. I've been an ardent supporter of independent pharmacies throughout my time in Congress. In both the 112th and the 113th Congress, I introduced legislation that would grant independent pharmacies a specific exemption to the antitrust laws when negotiating contract terms for provisions of health care items or services. This would have potentially given the vast network of isolated independent pharmacies a stronger competitive footing relative to larger national pharmacies. Whether this exemption is needed is another item to consider today. Many PBMs also provide pharmacy services either through their own brick-and-mortar locations or through mail-order services. As a result, PBMs may negotiate services with competitors to their own pharmacies. Over the years, this has resulted in tensions between certain pharmacies and PBMs. The antitrust enforcement agencies have periodically reviewed PBM activities, finding in some instances that these activities are appropriate. and stepping in when they are not. Today's hearing will allow us to become better educated about the services that PBMs and pharmacies provide. The hearing also will allow us to review whether the proper economic incentives are in place to ensure that customers are receiving affordable prescription drugs and to explore some of the historic tensions between certain PBMs and pharmacies. The public record generated today will also assist the committee with its oversight authority of the antitrust enforcement agencies. We have before us Express Scripts and CVS Caremark, two of the largest PBMs and pharmacy companies. They will provide an inside and first-hand perspective of PBM and pharmacy operations, as well as an invaluable viewpoint into the prescription and pharmacy industry at large. Additionally, we will hear from a representative of independent pharmacies and one of the experts covering both of these markets. I look forward to today's discussion from this excellent panel and witnesses. The chair now recognizes the ranking member of the Subcommittee on Regulatory Reform, Commercial and Antitrust Law, Mr. Johnson of Georgia, for his opening statement.
Thank you, Mr. Chairman. Today's hearing is a welcome opportunity to continue this subcommittee's examination of competition in the healthcare marketplace. The topic of today's hearing, competition in the pharmacy marketplace, will explore the role of pharmacy benefit managers, or PBMs, in ensuring competitive and affordable drug prices for American consumers. In the pharmacy marketplace, PBMs serve as the intermediary between the manufacturers and wholesalers of prescription drugs and the payers of health insurance benefits. In their role as the intermediary in this market, PBMs administer prescription drug benefits to approximately 95% of Americans who receive prescription drug benefits. Furthermore, through their contracts with health payers such as health insurance companies, PBMs are responsible for negotiating the cost and availability of prescription drugs with manufacturers and wholesalers. In short, PBMs are a critical gatekeeper in the prescription drug benefit system. It is therefore imperative that we fully understand the functioning of this market from both a competition and regulatory perspective to determine whether consumers are receiving the most affordable prices for prescription drugs. From a competition perspective, some have suggested that there is significant horizontal consolidation in the PBM market. And furthermore, that this horizontal consolidation is compounded by the vertical integration of certain PBMs into the mail order and retail pharmacy market. While the Federal Trade Commission has studied this issue on several occasions and reached the conclusion that the PBM market is adequately competitive, as Commissioner Julie Brill has noted, the FTC has not conducted a further study of the PBM industry since 2005, other than to review the ESI-Medco merger in 2012, which did not examine issues surrounding PBM plan design, such as PBM fee and compensation transparency. It is therefore incumbent upon this subcommittee to conduct a thorough inquiry on this matter, which I hope that today's hearing provides. From a regulatory perspective, it has also been suggested that PBM's pricing techniques, rebate schemes, and formulary designs have resulted in higher costs to consumers. I hope that today's hearing also serves as a fruitful discussion of this topic, particularly with regard to the Department of Labor's inquiry into this matter last year. As Consumers Union has noted, effective regulation and effective competition work hand in hand, and the less we can rely on effective competition, the more important it is that regulation ensures effective transparency to reduce the potential for abuse. I strongly agree. While the PBM marketplace is undoubtedly convoluted, today's hearing will serve as an important basis for determining whether consumers are receiving the best prices for prescription drugs, or whether we should do more to ensure affordable and transparent markets for prescription drugs. I thank the Chair for continuing this series, and before closing, I ask unanimous consent that the written statement of Lynn Quincy and George Slover of Consumers Union be made a part of the record.
Without objection, so ordered.
Yield back.
The chair now recognizes the full Judiciary Committee ranking member, Mr. Conyers of Michigan, for his opening statement.
Thank you, Mr. Chairman. I join you in welcoming the witnesses and look forward to a very frank and analytical discussion of the subject matter. Once, when I was chairman of the House Judiciary Committee, the committee reported legislation that would have granted a limited antitrust exemption for independent pharmacies to allow them to collectively bargain as to the terms and conditions of reimbursements from pharmacy benefit managers. This legislation arose from the recognition that small independent pharmacies struggle to compete against large pharmacy chains, particularly with respect to their ability to negotiate reimbursements from pharmacy benefit managers. Pharmacy benefit managers administer the prescription drug benefit portion of health insurance plans for private companies, unions, and governments. They're responsible for processing and paying prescription drug claims, contracting with pharmacies, and negotiating discounts and rebates with drug manufacturers, all for the ostensible purpose of keeping drug prices low for health plans. The hearing today gives us an opportunity to delve more deeply into the state of competition in the marketplace for pharmacy benefit managers and to consider its possible effects on consumers. To that end, we should keep the following in mind. As an initial matter, we should assess whether the market for pharmacy benefit managers is too concentrated and structurally problematic to maximize consumer benefits. Although estimates vary, most studies indicate that just 3 companies may control up to almost 80% of the pharmacy benefit manager market. Such concentration in any industry necessarily raises questions about whether the dominant firms can use their power to the detriment of their competitors and consumers. The largest pharmacy benefit managers also own retail pharmacy businesses, which can be in the form of a large national retail chain, specialty pharmacy business, or online mail-order pharmacies. According to some experts, these ownership arrangements create an inherent conflict of interest because a large pharmacy benefit manager can leverage its market power to benefit its retail pharmacy business by using exclusivity arrangements and providing more generous reimbursements to the detriment of small independent retail pharmacy competitors. Moreover, such concerns may be further exacerbated when the industry is relatively unregulated, as may be the case with pharmacy benefit managers. In addition, we should consider whether a lack of transparency with respect to operations of pharmacy benefit managers helps or hurts competition. Some critics of pharmacy benefit managers assert that the lack of transparency makes it difficult to assess whether they are fully passing on whatever saving they may obtain from drug manufacturers. These critics contend that the substantial rise in profits for pharmacy benefit managers in recent years suggests that such savings are not in fact being passed on to consumers. Critics further assert that it's hard to know whether pharmacy benefit managers are providing fair reimbursements for generic drugs to small independent retail pharmacies, given the lack of publicly available information about how pharmacy benefit managers determine such reimbursements. If these allegations are true, the lack of transparency may well make it difficult for health insurance plans to secure the lowest costs or the best quality service for consumers. Now, while some criticize what they see as lax antitrust enforcement in the pharmacy benefit manager marketplace, there's a broader question of whether more direct regulatory measures are needed beyond stronger antitrust enforcement. And that's what makes what the witnesses have to say here today very important as we on this committee decide what direction we should pursue. And I thank the chairman for the time.
Without objection, other members' opening statements will be made part of the record, and I ask unanimous consent to enter in some statements and documents for the record. Representative Carter, Republican from Georgia. Representative Blum, Republican from Iowa. America's Health Insurance Plans. American Pharmacists Association. Pharmaceutical Care Management Association. Hearing no objection, so ordered. I will begin by swearing in our witnesses before introducing them, so would you please stand and raise your right hand. Do you raise your right hand, please? Do you swear that the testimony you're about to give before this committee is the truth, the whole truth, and nothing but the truth, so help you God? Let the record reflect that all of the witnesses have responded in the positive. Please take your seat. We have 4 distinguished witnesses today, and starting at my left is Ms. Bricker. She is the Vice President of Retail Channel Management, Contracting and Strategy at Express Scripts Incorporated. Prior to joining Express Scripts, Ms. Bricker was the Regional Vice President of Account Management at Walgreens Health Services, as well as the Director of Community Retail Pharmacy at BJC Healthcare. Ms. Bricker is a graduate of St. Louis College of Pharmacy and is a registered pharmacist in Missouri. Welcome. Mr. Balto, who's been with us before on other occasions, is an antitrust attorney with over 15 years of government antitrust experience. Mr. Balto worked as a trial attorney in the antitrust division of the Department of Justice and in several senior level positions at the Federal Trade Commission during the Clinton administration. He received his BA from the University of Minnesota and his JD from the Northeastern University School of Law. Welcome, sir. Ms. Pons is the Senior Vice President and Assistant General Counsel at CVS Health. Prior to joining CVS in 2011, Ms. Pons was the Chief Compliance Officer at Advanced PCS and a Senior Legal Counsel at PCS Health Systems. Ms. Pons earned her bachelor's degree in Business Administration from the University of Iowa College of Business and her JD from the University of Iowa College of Law. Welcome. Mr. Arthur is the President of the National Community Pharmacists Association and the owner of 2 independent pharmacies in Buffalo, New York, which have been serving their community since 1957. Mr. Arthur is active in the pharmacist community and has served on various business and pharmacy boards during his career. Mr. Arthur earned his Bachelor's of Science degree from the University of Florida College of Pharmacy and his Micro MBA certificate from the State University of New York at Buffalo. Each of the witnesses' written statements will be entered into the record in its entirety. I ask that each witness summarize his or her testimony in 5 minutes or less, and to help you stay within the timer, there is a light in front of you. Now, as I am intent on making my statements, I'm not looking at any lights and I'm not looking at any clocks. I have people up here to nudge me. What I will politely and diplomatically do when we're getting close, when you hit that 5-minute mark, I will again diplomatically raise the gavel and try to get your attention and ask you by doing that to wrap up your statement. If you would do that, please. Ms. Bricker, would you like to make your statement, please? Turn on the microphone, please. Thank you.
Chairman Marino, Ranking Member Johnson, and other members of the subcommittee, my name is Amy Bricker. I'm a licensed pharmacist and serve as Vice President, Retail Contracting and Strategy for Express Scripts. Thank you for the opportunity to be here today and share our perspective on competition in the pharmacy benefits manager and pharmacy marketplaces. Express Scripts is the nation's largest pharmacy benefit manager, or PBM. We provide pharmacy services to roughly 86 million Americans covered by our clients, which are large employers, health insurers, labor unions, TRICARE, Medicare, Medicaid, and marketplace plans. Express Scripts employs more than 25,000 hardworking, dedicated employees nationally. We have more than 2,000 employees in Pennsylvania and more than 700 in the state of Georgia. Our number one goal is to make prescription drugs safer and more affordable for our patients and clients. Everything we do as a company is aimed at that goal. In a changing system, the demand for pharmacy services and prescription drugs has never been stronger. When used properly, prescription drugs keep patients healthy and costs lower for everyone. As the subcommittee examines PBM and pharmacy competition, we want to emphasize 3 takeaways. First, the PBM marketplace is extremely competitive. Dozens of national and regional PBMs offer payers competing services and products. PBMs compete on price, data analytics, customer service, pharmacy access, clinical support services, and many other factors. Payers have a wide choice of PBMs and use that power to demand favorable pricing and contract terms. Express Scripts is an independently operated PBM. Some PBMs are owned by chain drugstores, while others are owned by health insurers. We believe our independent business model provides our clients with a clear choice when choosing a PBM. By operating separately from both the supply chain and the distribution channels, we stand alongside our clients as an independent counterweight in the marketplace. Second, scale matters. Express Scripts scale allows it to negotiate discounts from drug manufacturers and pharmacies that lower costs for our clients and patients. Express Scripts creates competition by forcing drug makers to compete against one another for placement on planned formularies and to gain market share. In a similar way, Express Scripts creates competition among more than 68,000 retail pharmacies nationwide. We contract either individually with retail pharmacies or through group purchasing organizations called PSAOs, which represent networks of pharmacies. Like large chain pharmacies, PSAOs combine the bargaining power of thousands of independent pharmacies when negotiating with PBMs. In fact, the largest PSAOs are as sizable as chain pharmacies. Under Medicare Part D, the TRICARE program, and some private plans, we must ensure patients have access to a minimum number of pharmacies within a region. In rural areas, independent pharmacies know that Express Scripts needs them in our network to meet Medicare access rules and thus command a premium. In a changing system, our scale helps drive savings. Brand drug makers may have short-term pricing power when bringing a breakthrough drug to market. However, our scale helps level the playing field when a brand or generic competitor emerges. Scale also allows us to drive a hard bargain and lower costs for patients, clients, and taxpayers. In 2014, prescription drug spending grew more than recent years. Much of this growth was driven by an increase in the unit cost of prescriptions, the prices manufacturers charge. But across our clients, closely managed plans spent nearly 1/3 less per member on traditional medications when compared to unmanaged plans. The tools we use help lower costs for clients and patients. Any effort to undermine our tools will mean higher costs for patients and payers. The third takeaway relates to independent pharmacies. In a changing system, independent pharmacies are more than holding their own. This is great news. The National Community Pharmacists Association recently published its annual digest, and it contains important data. 1, the number of independent pharmacies has held steady over the past 4 years, even with the increasing rate of acquisition of independents by retail chains. 2, over the past decade, gross profits have held steady at around 23%. And third, over the past decade, annual sales per store have hovered between $3.6 and $4 million per year. In conclusion, Express Scripts values our relationships with our pharmacy partners, including independent pharmacies. Without independent pharmacies, we could not offer clients and patients a high-quality pharmacy benefit. The key lesson of the past 5 years is that affecting change requires stakeholders to work together. Rather than pit one part of the pharmacy against another, we can and must work together to lower costs for payers and improve patient outcomes. Thank you again for the opportunity to be here today. Chairman Marino and Ranking Member Johnson and other members of the subcommittee, I'm happy to answer any questions that you might have.
Thank you. Mr. Balto.
Thank you, Mr. Chairman, Ranking Member, for inviting me to testify today. This is a very important subject. My testimony today is based on my years as a government enforcer and in representing consumers, public interest groups, PBMs, payors, and pharmacies in PBM matters. And I've testified on several occasions for consumer groups. I have a simple message. By any measure, the PBM market is severely broken. If you look at my testimony on pages 7 and 8, you see that profits are increasing rapidly, margins are increasing rapidly. By any measure, this market is not behaving competitively. Why is that? Normally, for a market to function effectively, you need 3 things: choice, transparency, and a lack of conflicts of interest. On all 3 of these measures, the PBM market receives a failing grade. Think about just the issue of my testimony documents how as drug prices are increasing, PBMs are increasing their profits too. They're profiting from increased prices through increased rebates. You don't have to guess about this. If you look at page 7 of the Consumer Union testimony, they document instances where there have been government enforcement actions where PBMs have forced consumers to higher price, less efficacious drugs in order to maximize their rebates. Now, normally, a payer faced with this situation would go and ask for information on rebates, but the PBMs won't provide that. They won't provide that kind of transparency. Now, in the Department of Labor proceeding that the ranking member mentioned, the Department of Labor is considering careful regulation to require transparency. And on one side of the table, you have Fortune 50 corporations, Consumers Union, and the AFL-CIO all saying, we want that greater transparency. And who pops into the room but the FTC? And the FTC says, no, transparency regulation would be a bad idea. We know what marketplace realities are, but economic theory teaches us that transparency would be bad. I don't know what counts as regulatory chutzpah to this committee, but to me that's really regulatory chutzpah. Obviously the Department of Labor and other entities should go and regulate and require the kind of transparency that these PBMs fight tooth and nail to try to avoid. Why do these problems occur? Because the FTC has effectively made this a regulatory-free zone. They've stopped investigating mergers. The last 2 big PBM mergers, they didn't even require a document or conduct a deposition, including CVS's acquisition of Omnicare, which major consumer groups cried out, do an investigation, but the FTC said no. What does this mean for consumers? First, it means these folks can go and merge at will. If these 2 companies wanted to merge tomorrow, if they wanted to go to the FTC's marriage chuppah, and asked to be merged, we don't know what would keep the FTC from saying no by the standards they're applying today. But there are worse effects. When you wonder about why Walgreens would acquire Rite Aid, it's so that they can battle against the dominance of these PBMs so they can have a fair seat at the table. Now, that may or may not be a good merger, but that's it. The need for that merger is on the FTC's doorstep. But when you create an enforcement-free zone, everybody listens. It's not just the PBMs who will engage in increasingly abusive conduct. increasingly abusive conduct. It's everybody else. So a pharmaceutical manufacturer who says, what keeps me from increasing prices 6,000%? The FTC's asleep at the switch. Let me do that. What does this committee need to do? First, pass legislation to provide for fair MAC transparency. The consumers care about whether or not community pharmacists know what they're buying a drug for, because that pharmacist is the consumer's agent. And when they're forced to dispense drugs below cost, everybody suffers except the PBMs, which are increasing their profits. Second, go and investigate in restricted networks. Restricted Part D networks, but especially restricted networks for vulnerable consumers who have critical disabilities and need specialty drugs. Specialty drug spending is increasing dramatically. That's the major mover to drug spending. And having a market where the PBMs increasingly force consumers into their own specialty pharmacies is sort of like putting the fox in charge of the hen house. Third, the PBMs have there's a new approach in going and attacking patient assistance programs. Patient assistance programs are programs by pharmaceutical manufacturers to enable patients to afford drugs they might otherwise not be able to afford. Those also should be investigated. The most important thing I say in my testimony, and I really urge the committee to spend time looking at this, is what I say on page 6. It's really heartfelt, and it's based on years of representing consumers. Who represents the consumer when in getting drugs? It's the pharmacist who represents the consumer. The pharmacist, as the chairman has indicated, who will go to battle with the PBMs to make sure the consumer receives the right drug at the right price, and they need to be protected. I welcome any questions you have.
Thank you, sir. Ms. Pons.
Thank you. Good morning, Chairman Marino, Ranking Member Johnson, and members of the subcommittee. My name is Natalie Pons, and I'm Senior Vice President and Assistant General Counsel of CVS Health. We appreciate the opportunity to testify on the critical role that pharmacists and pharmacies play in local communities all across America in providing convenient access to affordable, high-quality prescription drugs within the vibrant marketplace in which we compete. From our company's earliest days, CVS Health has been singularly focused on helping people on their path to better health. Our values are the same as those of our consumers, businesses, and communities we serve. We want to make health care more accessible and help improve health outcomes in more affordable, effective ways. Our goal is to work with health plans, employer plans, and government plans who contract with us to ensure that their enrollees have access to a well-coordinated, safe, and affordable prescription drug benefit. Our patient-centric model is organized around how consumers access and use medication. It provides multiple points of care and extends across all of our business units. Our pharmacy benefit management program, our retail, mail, specialty, and long-term care pharmacies, our Medicare Part D plan, and our MediClinics. In addition to our active medication adherence and care coordination for chronically ill patients, we also provide access to key preventative care such as vaccinations, smoking cessation, and weight loss programs. Our overriding commitment to improving Americans' health is the main reason we decided to end tobacco sales last year and forego $2 billion in annual revenue. CVS Health is proud of its commitment to and success in constraining prescription drug costs. Through the discounts and savings we share with our consumers, business, labor, health plan, and government partners while helping to improve outcomes. Using our clinical tools, we're able to help keep premiums low and save tens of billions of dollars for patients, employers, and taxpayers. Our success is driven by on how effectively we help our partners and patients achieve the best return on their health care dollars. We manage prescription drug benefits on behalf of a diverse set of purchasing partners that include health plans, as well as employer and government plans, including Medicare Part D and state-managed Medicaid programs. Healthcare purchasers rely on pharmacy benefit managers to negotiate the lowest possible prices from drug manufacturers, put together networks that provide convenient access to pharmacists and pharmacy services, and provide a portfolio of clinical programs and services that help ensure positive health outcomes and secure overall value for both the patients and clients alike. To help us achieve this outcome, we encourage the use of cost-effective generics over more expensive branded products, which helps consumers and plans save money on prescription drugs without compromising clinical efficacy. To be clear, though, our role in the design of these plans is advisory. The plans always have the final say when creating their drug benefit and how it's implemented. Competition in the PB industry has been aptly described as vigorous by the Federal Trade Commission. In fact, there are 30 different large and mid-sized PBMs that offer businesses, labor, consumers, and government a variety of choices when considering options for best managing a pharmacy benefit. In addition, the pharmacy marketplace is a very competitive one. With over 60,000 pharmacies in the United States, consumers in all parts of the country have many outlets to fill their prescriptions. To ensure broad-based access, our PBM contracts with every category of pharmacy, including drugstore chains, grocery stores, and over 20,000 independent pharmacies. We welcome competition. Indeed, our success is predicated on it. Healthy competition drives innovation and allows us to effectively help the consumer, business, labor, health plan, and government partners that we serve achieve the best returns on their health care investments. We look forward to working with the members of this committee and others to continue promoting a competitive healthcare landscape. Thank you for this opportunity to testify, and I'll be happy to take your questions.
Thank you. Mr. Arthur.
Thank you, Chairman Marino, Ranking Member Johnson, and members of the subcommittee. Thank you for conducting this hearing today and providing me the opportunity to share my views and personal experiences regarding the state of competition in the pharmacy benefit manager and pharmacy marketplace. My name is Brad Arthur, and I'm a pharmacist owner of 2 independent pharmacies in the Black Rock community of Buffalo, New York, a very historic, ethnically diverse, and predominantly blue-collar community. My pharmacies have been serving these communities since 1957, when my dad opened his first pharmacy. I'm also the president of the National Community Pharmacists Association, which represents the pharmacist owners, managers, and employees of nearly 23,000 independent community pharmacies across the United States. I'm here today as a healthcare provider, a small business owner, and hopefully to present some of my experiences and those of my fellow independent pharmacists in dealing with the PBM industry. Community pharmacies represent the most accessible point in patient-centered healthcare, where typically consumers do not need an appointment to talk with a pharmacist about prescription medications, over-the-counter products, or really any health-related concern. In this way, community pharmacies also serve as a safety net healthcare provider on the front lines, not only in natural disasters, which occur often in Buffalo, tornadoes, hurricanes, flooding, whatever it may be. Every day when patients need help, their independent pharmacies are there to assist. According to the Pharmaceutical Care Management Association, PBMs manage pharmacy benefits for over 253 million Americans. 3 large companies lead the PBM market: Express Scripts, CVS Health, and Optum Rx. In total, they cover more than 180 million lives in the United States, or roughly 78% of Americans whose pharmacy benefits are managed by a PBM. In addition, the annual revenues for these 3 entities are staggering. In 2014, annual revenues for Express Scripts were approximately $100.9 billion. Annual revenues for CVS Health were $139.4 billion, and for Optum Rx, $31.97 billion. In 2015, Optum Rx acquired Catamaran, another PBM, which reported annual revenues to combine into that number of $21.6 billion. Why should the federal government be concerned about this dynamic for large plans, including the federal Medicare Part D program, which was mentioned today, TRICARE, the FEHBP? There are only 3 PBMs to choose from. Because although there are other PBMs, none of them, in spite of what we've heard, are large enough to administer the prescription drug benefit for these programs. The big 3 PBMs control almost 80% of the entire market, and these PBMs have the upper hand both in negotiating the contract with the payer as well as strongly influencing the actual plan design itself. The PBM industry typically states that they can use their economic power to harness enhanced market efficiencies. But for whom? However, the staggering annual revenues that continue to grow each year of the Big Three suggest that these efficiencies are going directly to their corporations' bottom lines. Small community pharmacies like mine are faced on a daily basis with the impact of the PBM's disproportionate market power. Community pharmacies routinely must agree to take it or leave it contracts from the PBMs just to continue to serve our longstanding patients. As if that weren't enough, the PBMs also directly set the reimbursement rates for pharmacies. The very same pharmacies that stand in direct competition of some of these PBM-owned mail-order and specialty pharmacies. Therefore, it comes as no surprise when the PBMs present employer and government payers with carefully tailored, suggested plan designs that steer beneficiaries to these PBM-owned entities. As the owner of 2 pharmacies, I have limited ability to negotiate network participation or reimbursement terms with these entities. However, from a business standpoint, community pharmacies can't just walk away from these contracts. If we did, I would lose a significant amount of the prescription revenue, given the large share of these covered lives that these PBMs represent. Although many independent community pharmacies rely on pharmacy services organizations to contract on their behalf, these PSAOs are no match for the PBMs. In 2013, the GAO conducted a study on the role of in the ownership of the PSAOs and stated that over half we spoke with reported having little success in modifying certain contract terms as a result of the negotiations. This may be due to the PBM's use of standard contract terms and the dominant market share of the largest PBMs. Many PBM contracts contain standard terms and conditions that are largely non-negotiable. Mr. Chairman, that's the conclusion of my testimony. I welcome any questions.
Thank you. The chair now recognizes the chairman of the full Judiciary Committee, Mr. Bob Goodlatte of Virginia, for his opening statement.
Thank you, Mr. Chairman. In late July, Chairman Marino, Ranking Member Conyers, Ranking Member Johnson, and I announced a series of committee hearings focused on competition in the healthcare marketplace. Today's hearing is the third in this series and will examine the competitive dynamics within the Pharmacy Benefit Manager, or PBM, and pharmacy markets. PBMs oversee the administration and management of prescription drug benefits. In that capacity, PBMs interact with nearly every step of the prescription drug supply chain. Consequently, they have the ability to extract lower prices for prescription drugs and have had some success in doing so. However, notwithstanding pressure from PBMs, drug prices continue to rise. A recent Wall Street Journal investigation found that increases in drug prices routinely outpaced inflation and often by a significant amount. These increases were found despite reduced demand for the drugs studied and even in the face of new competing drugs. If true, this represents a troubling trend as Americans face a progressively aging population and an ever-growing amount of taxpayer money used to fund the purchase of prescription drugs. Through today's examination of competition within the PBM and pharmacy markets, we should explore whether the proper economic incentives exist for PBMs and pharmacies to place a genuine check on rising drug prices. Another challenge facing the country and my constituents is affordable and accessible health care in rural communities. Independent pharmacies play a critical role in the delivery of personal prescription drug care, especially in rural areas. During my tenure in Congress, I have seen many community pharmacies in my district shutter their doors. While we should allow the free market to operate, we should also ensure that there is a level playing field for both large and small pharmacies. Today's discussion will help shed some light on the nature of the competitive playing field in the pharmacy market. Since the enactment of the Affordable Care Act, I consistently have expressed concern that the law would compel consolidation across a number of healthcare industries. My fears appear to be coming true. Both the PBM and the pharmacy markets have experienced consolidation in recent years. Indeed, Walgreens and Rite Aid recently announced their intent to merge, and CVS's purchase of Target's retail pharmacies is currently under review at the Federal Trade Commission. This committee has held hearings on past PBM consolidation, including the merger between Express Scripts and Medco. While this hearing is not intended to review the details of any particular transaction, we should examine how these trends have impacted competition in both the PBM and pharmacy markets. Specifically, it will be helpful to learn what effects these transactions have had on prices paid by Americans for prescription drugs. Most importantly, we should explore whether market forces compelled these transactions or the Affordable Care Act and its regulatory progeny are prompting increased consolidation. We have an excellent panel of witnesses before us today who can provide us with firsthand perspectives on the competitive issues facing PBMs and pharmacies, and I look forward to hearing their testimony. Thank you, Mr. Chairman.
We're going to go into our 5 minute of questioning, and as is once in a while customary, I'm going to wait and ask my questions last today because I really want to hear what the panel has to say. And so I'm going to recognize the chairman of the full committee, Mr. Goodlatte, for his 5 minutes of questioning.
Thank you, Mr. Chairman, and I thank all the witnesses for their testimony today. I want to direct this question to both Ms. Bricker and Ms. Pons. We've all heard about the dramatic spikes in the price of certain prescription drugs that were previously in the market for a significant period of time at stable prices. In fact, I was speaking about this particular issue just yesterday with pharmacists in my district. On a number of these drugs, pharmacies end up taking a loss if they dispense them. I understand that you're not the drug manufacturer. However, you do have a role to play in negotiating the price and reimbursement of these drugs. Can you comment on this current situation? I'm familiar with one Ritalin generic drug that has gone from about $125 for a 30-day supply to about $600 for a 30-day supply just this year. I'm familiar with a tube of a medical cream that's gone from about $100 for the tube to $2,000 for one small tube. This very much concerns me, and I'd like to know what your perspective is on how this pricing is taking place and what you as the insurer are doing to try to hold down these prices and hold these companies accountable.
Thank you, Congressman, for the question. You know, high drug prices are not a new phenomenon. We have seen this in, over decades of managing prescription benefits. At Express Scripts, we encourage competition. We believe that competition results in a decrease in drug pricing. Oftentimes, when drug prices increase, it's due to a shortage or it's due to a number of manufacturers coming out of the market. And so, with competition, you see a decrease in price. We're advocates for biosimilars and technology and in negotiating inflation protection from our brand manufacturers to pass on to our clients as well as their members. So, with that, I understand the need. We hear from our plan sponsors regularly about the concerns that they have around increased drug prices, and through our tools from a clinical perspective, it is our hope to continue to manage that drug benefit in partnership with our plan sponsors.
Ms. Pons?
Thank
Do
you.
you put pressure on these manufacturers to offer more reasonable prices, since you're a large purchaser or you're a large insurer of, and CVS, your case, a large purchaser of them as well?
Yes. Every day, our company gets up, and what we do is try to get the best prices on behalf of our clients to help keep their premiums down for their members and help keep plan or costs affordable. And we'll agree, there have been some very egregious examples in the marketplace that I think we all find shocking. Beyond that, as Ms. Bricker testified, we do think that a combination of the clinical tools that we have available, as well as our ability to negotiate with pharmaceutical manufacturers, together with some of the important policies that she talked about in terms of getting more competitive market products into the marketplace, whether that's more generics, more biologics, lower cost of site of care, things of that. Those things in combination can go a long way to helping curb these issues.
Let me ask Mr. Arthur if he'd like to respond.
Yes, thank you, Mr. Chairman. I would like to add that while prescription drug prices have historically gone up at a rate greater than the normal cost of inflation, throughout most of my career, the trend was just the opposite on the generic side. As more generic manufacturers enter the marketplace, the trend has always been for the price to come down as the market responds. What's interesting to note is that these extremely large business entities have the sophistication, and the examples that you alluded to meet this out. They have the sophistication to respond to these market fluctuations very quickly. The pharmacists that you heard from were expressing frustrations because when the price of the drugs goes down, the PBM have no problem implementing those as the basis for reimbursement, sometimes overnight. But there's a significant lag that is seriously to the detriment of the independent community pharmacists because they're oftentimes saddled with dispensing these much-needed medications at a loss.
Let me ask both Ms. Bricker and Ms. Pons another question as well. Both Express Scripts and CVS operate PBMs as well as pharmacies. Some have raised concerns that PBMs in your position have a conflict of interest due to the fact that your PBMs negotiate contracts with pharmacies that directly compete with pharmacies owned by your corporate parent. What is the risk of your leveraging your role as a PBM to gain a competitive advantage against pharmacies that are outside your corporate families? And let me give you an example here, too, as well. Pharmacist yesterday showed me a drug. I can't remember what it was, but the reimbursement rate from the PBM was $300 and some less than the price of the prescription drug. Now, they cannot, because of their contract with the PBM, they can't turn around and tell the purchaser, well, I'm sorry, I can't sell you that drug for that price. They can't turn around and tell them, I'll sell it to you, but you'll have to make up the difference. If they want to sell that prescription drug to that regular customer they have to eat that $300 and some cost. How is it that the insurance company can justify that, knowing the costs and knowing that you're in a competitive environment, but with a bigger company and therefore able to manage these costs in ways that a small pharmacy can't? How can that policy be justified of having to say, sorry, this is all we're going to pay you, and you can't do anything but eat the rest of that cost? How can a small pharmacy stay in business in that environment?
Yeah, that's an excellent question and a fair question to ask. You know, we put together our MAC list so that we can encourage pharmacies to try to buy generic products at the lowest possible cost. Having said that,
some of these were generic products, as Mr. Arthur noted.
Right.
In fact, the Ritalin was a generic product that had gone up quadrupled in price over a very short period of time.
Yeah. And so we want them to buy them at the lowest possible cost, but we also want them to get a fair margin. In order for us as a PBM to meet our commitments to our clients, we need to have our network have a very high dispensing of generic rates within the network. If we are paying pharmacies prices that are lower than their acquisition costs, pharmacies aren't going to do that. So we try very, very hard to make sure that they get a fair margin. Are there going to be times when a particular drug, they're underwater? Absolutely. But what we do look at the pharmacy's overall reimbursement across all of their generic claims to try to ensure that they're getting a fair margin so that they're incented to dispense as many generics as possible.
They showed me their records for a particular day, and on that day they sold, I don't know, they have two stores in their operate. They sold $15,000 worth of drugs, and the total across that entire was a net loss of a few $100s. Again, I understand, you know, some are going to be high and you can't always hit it right, but if the average is a net loss on a daily basis, how do pharmacies stay in business?
Yeah, the other thing I would say, and I think this is typical for other companies in the industry, there is an appeals process so that if that's happening, you know, we're making certain assumptions because we don't know what every pharmacy in the network is buying their product at. We're trying to do our best to estimate what their cost is. And if there are situations where they're losing more than they're winning on, there's an appeals process so that we can address that. Again, it's not in our interest to have pharmacies not want to dispense generics because that's going to cost our clients more money.
Thank you, Mr. Chair. My time is long expired.
Thank you.
Chair now recognizes the ranking member, Mr. Johnson.
Thank you, Mr. Chairman. Mr. Balto, please explain how a lack of transparency in the PBM marketplace may be undermining competition and consumer choice. And limit your answer to 1 minute, please.
Oh, it's very simple. I mean, when you look at the problem of escalating drug prices, one thing people would want to know is what's happening to the rebates. And since the merger of Express Scripts and Medco has occurred, it's even harder for plans I represent, to get that kind of rebate information. If they got the rebate information, they could make sure the right decisions are being made, and they could get more of the rebates, and that would result in lower costs to consumers.
Thank you. Mr. Arthur, some of your fellow witnesses contend that PBMs benefit consumers because their scale allows them to negotiate effectively with drug companies to keep patient premiums and cost sharing manageable. What's your response to that?
While that's a noble goal, I don't believe that to be the case. I think the scale that is employed is often for the betterment of the parent corporation. We see numerous examples with the implementation of Medicare Part D in the donut hole. It wasn't uncommon for us to see patients, due to the pricing methodologies of the large PBMs, to be thrown in the donut hole prematurely. So we've all discussed about the need to use scale to drive down costs to consumers. The reality in the marketplace is we haven't necessarily seen that to be the case.
All right, thank you. Mr. Balto, why do you believe the Federal Trade Commission has not been vigorous enough in its enforcement efforts with respect to PBMs? And give me this in 30 seconds.
I think they've allowed economic theory to replace marketplace realities, and they're failing to see the real harm to consumers and plans and the limitations of their choices.
All right, thank you. Ms. Bricker, Mr. Balto suggests that rapidly rising profits in recent years suggest that PBMs are not fully passing on savings from drug manufacturer rebates and discounts on to health plans and consumers. What's your response to that?
Our clients demand transparency. I can't speak to, clients that Mr. Balto represents, but the clients that Express Scripts represents, demand transparency. We feel that the additional transparency that is being suggested could be harmful, actually, to competition, resulting in price fixing and potentially collusion.
Your response, Mr. Balto, 30 seconds.
In a competitive market, profit per script would not be increasing by 75% in a 3-year period. That's a clear sign that the Express Scripts Medco merger has been anti-competitive and consumers are being harmed.
Okay. Ms. Pons, CVS recently completed the acquisition of OmniCare, a very large provider of long-term care pharmacy services. From a consumer and patient's perspective, this could be concerning, as now your company is both a retail pharmacy, PBM, and LTC provider with a sizable market share. Although the acquisition is very new and you're still working on the integration, what assurances can you provide today that this will not negatively impact the level of service and care to some of the nation's most vulnerable and fragile patients residing in nursing homes?
Thank you for that question, Ranking Member Johnson. It is a new acquisition. We are, I think, 4 months into this after, spending an extensive process with the FTC going through this. This is a completely new line of business for CVS Health, but one that we thought was very important to continue our various touch points that we have with patients, and as you point out, a very vulnerable patient set. And we think that with our other assets that we have for those patients that leave those facilities, that we can better integrate them and coordinate their care better. So we feel like it's a great addition to what we do best, which is trying to coordinate care at the lowest possible costs and improve outcomes, and we're anxious to move forward with it.
All right, thank you. Last, Mr. Arthur, some of your fellow witnesses, well, I see I'm out of time, so I will, okay, all right. In response to concerns about unfair terms between independent pharmacies and PBMs, some have argued that pharmacies could simply refuse to accept the PBM's proposed terms and conditions or come together to negotiate more acceptable contract terms. Why is this not a sufficient answer in your view?
Sir, to answer the first part of your question, 98% of my business's revenue comes from third-party agreements, be they from the private side, the commercial side, or from the government payer side in the form of Medicare, or Medicaid, excuse me. Turning away from that business is not a realistic option that I have. I would have no recourse but to close my doors. So we're in an extremely anti-competitive position from that point of view. The second part of your question, we have turned to these entities as an attempt to negotiate, but they have also faced some of the same barriers that we have to truly negotiate contracts. When given the opportunity, I, as a small independent business, have tried to strike certain terms from agreements only to have them pushed back with a take it or leave it answer. So we haven't been successful in negotiating these either independently. We certainly cannot get together as a bunch of independents. That would be collusion. We have tried to circumvent that, not circumvent, we have tried to meet that challenge by using these contracted entities, but they have also shared with us that they are a very small fish in a big pond and are not successful at truly negotiating terms.
All right. Thank you, Mr. Arthur, and thank you, Mr. Chairman.
Chair recognizes Mr. Radcliffe from Texas.
Thank you, Chairman Marino. Of all the issues that we examine here in Congress, perhaps none is more personal than that of health care. Americans literally trust our health care professionals with our lives, and pharmacists are an essential part of that health care, particularly in the communities in North and East Texas that I represent, because in many of those towns, there are big chain drugstores, but most of the towns in the district that I represent depend on local community pharmacies that have been there for decades. And as the healthcare landscape evolves and becomes, frankly, increasingly complicated, I want to make sure that we protect the pillars of the community in those types of towns in my district. So, Ms. Bricker, let me ask you a question. It's my understanding that your company may not update their reimbursement rate often enough to keep up with fluctuations in the marketplace. That concerns me because if a certain generic drug price drops rapidly, and if that drop isn't updated quickly, it would seem to me that Medicare could be paying more for a generic drug than it should. Is that a legitimate concern?
Thank you for the question, Mr. Congressman. At Express Scripts, we have teams of people dedicated to this very subject, ensuring that we're responsive to the marketplace, surveying the marketplace to ensure that our pricing is appropriate for our community and all retail pharmacies. We're updating no less frequently than every 7 days. There are laws on the books in over 20 states across the country that also enforce this very thing, and so Express Scripts is compliant and takes seriously those laws.
Well, I get that it's compliant and every 7 days is good, but is it a legitimate concern in that 7-day period that type of price fluctuation can occur so that Medicare is paying more for a drug than it should?
So we're the least frequently that it would occur is every 7 days. We're reviewing it daily, and if there's a dramatic price change that occurs, within, prior to that 7-day change, we'll make the change earlier as well.
Okay, so I understand the cost of generic drugs has really skyrocketed the last couple of years now. How often do you update your MAC lists, those reimbursement lists?
No less frequently than every 7 days, but we're
okay.
looking at it every single day. And so if there's a change that needs to be made, the following day we'll do that.
Okay, so are pharmacists able to see in real time what their reimbursement for dispensing on a generic drug is, or are there fees being charged to pharmacies after the point of sale?
Directly at the point of sale, as you're standing at the counter, the pharmacist is processing the prescription, submitting vital information to the PBM, and in exchange, in roughly 3, 5 seconds, they're receiving a response on what copay to collect, if any, and what reimbursement they will receive.
Okay, thank you. Ms. Bonds, same question for you about the MAC list. How often are you updating them?
Exactly the same. We have a team of people that are constantly monitoring various market sources to see what's happening with drug acquisition costs and are compliant with state laws, but if there are market forces that suggest we need to make updates sooner than that, we do.
Okay, thank you. So, Mr. Arthur, we're frequently told that PBM contracting terms are unfavorable to many of the independent pharmacy owners out there. However, the PBM industry claims that those issues really shouldn't be resolved by legislative bodies, but instead should be left to the contracting parties. I guess my question to you is, if the terms contained in PBM contracts are egregious, why don't pharmacies simply refuse to accept the proposed terms and conditions or come together to negotiate more acceptable contract terms?
I don't think it's really practical for us as small business owners to just refuse those contracts, because as we learned earlier today, it impacts such a significant portion of our business that to walk away from those contracts would be a death knell to our businesses. And I think it's very telling to your question that the reason there's timely updates to MAC in 20 states is because the independent community marketplace pushed for that. That didn't come voluntarily. So we had to push for that timely in 20 states, and we continue to push for that across the entire country. So that has been our approach to try to create some fairness in the marketplace. We continue to try every day to negotiate some of these egregious terms so that we can be more competitive. But the fact remains today that we're at such a disadvantage because a significant portion of our customer base, our patient base, is impacted.
Thank you, Mr. Arthur. I see my time's expired. I yield back.
Thank you. The chair now recognizes Congressman from Rhode Island, Mr. Cicilline.
Thank you, Mr. Chairman, and thank you to our witnesses. I want to welcome you and certainly thank you for your testimony, and I particularly want to acknowledge the extraordinary corporate citizenship of CVS, a company that I have admired for a long time, particularly when it made its very courageous and impactful decision to forego selling tobacco products at the loss of $2 billion in revenue, but I think really set an example for healthcare companies, and I just want to publicly applaud you for that. I want to go first in response to you. Mr. Balto has said in his testimony, both in his written testimony here today, that plan sponsors need more transparency in order to make sure they're receiving the full benefits of PBM's bargaining power and to make sure that PBMs effectively rein in drug costs. It sounds like a reasonable proposition. Would you respond to that claim?
Yeah, no, we are fully supportive of transparency with our clients. What we're not supportive of is transparency of our proprietary information with our competitors. And in fact, I think the FTC has said on a number of occasions that transparency can actually have the opposite effect in terms of reducing costs. And so our clients have very extensive audit rights, which they exercise regularly, and to ensure they're getting the benefit of the bargain that they struck with us. So we are completely supportive of transparency with our clients, and if we did not make that available to them, they would look for another vendor that did.
And so is it fair to conclude that your assessment is that the transparency related to your relationship with the pharmaceutical company, that it could produce higher costs for the consumer?
We believe that if our competitive pricing that we have with our clients was made more publicly available and our competitors were aware of that, whether that's rebates or network rates or other proprietary terms, we believe that that could actually result in higher prices because there isn't an incentive to make your prices lower because then everybody's cannibalizing the market.
And Mr. Balto also argued that PBM's exclusivity arrangements with some drug manufacturers can keep drug prices artificially high by keeping lower priced drugs off the market and by incentivizing PBMs through manufacturer rebates to switch patients from prescribed drugs to more expensive alternatives. Would you respond to that argument?
Yeah, I guess I would just say that's a little foreign to my experience in working with the PBM day in, day out. We make formularies available to clients. Typically, generics are on the first tier, preferred brands, and then non-preferred brands. And the client can either elect to have that formulary or choose one for themselves or make one up for themselves. And that's what is the foundation of their plan benefit. You know, my experience is clients are very smart, they're very demanding, they're sophisticated. If they don't have that sophistication themselves, they'll hire consultants that do, and they're going to look for the best possible deal for themselves as well as offering an attractive benefit to their plan members.
So some consumer groups have argued that PBMs keep the proceeds of rebates and discounts and keep a disproportionate share of that for themselves, and so that one could conclude from the rising profits of PBMs that they're not fully passing on savings to health plans and consumers. But despite that, there is a report from the FTC in August 2005 that shows that PBM-administered prescription drug coverage paid between 15 and 50% less for drugs than non-insured consumers buying the exact same drug. And so I'd first ask unanimous consent, Mr. Chairman, that this be made part of the record, and I'd ask Ms. Pons if you could respond to that claim and the findings, because my interest is what will get to my constituents the lowest cost. And we talk a lot about another effort to permit the federal government to negotiate discounted prices directly with the pharmaceutical companies through the Medicare program, which they're prohibited from doing. It seems like PBMs are at least achieving that through their scale. It seems as if that's what the report concludes, and I would just like you to respond to that.
Yeah, no, and I think there have been a couple of different reports. The one I think you're referring to is the one in 2005 where they investigated whether there was in fact a conflict of interest between PBMs and owning mail service pharmacies, and the findings of that report was that they did not believe there was, and that they saw that there were more savings with the PBM-owned mail versus a non-PBM-owned mail pharmacy, as well as over retail pharmacies, and that mail service pharmacies were very good at generic dispensing and were very closely aligned with client incentives.
And Mr. Chairman, if I may just ask one final question. Mr. Balto argues in his written testimony that there's a, quote, increasing disregard of the antitrust laws in the pharmaceutical area, and argues as a result that consumers suffer from a lack of choice in the marketplace. And in 2009, your company was actually investigated by the FTC based on allegations of anti-competitive behavior. I'd wonder if you would just briefly state what the conclusions of that were, and I would ask unanimous consent that a letter from the Federal Trade Commission dated January 3, 2012 be introduced.
Without objection, so ordered.
Yes, we did go through an investigation after the CVS Caremark merger that started in 2009 and I believe ended in 2012 that looked at a number of activities, but primarily trying to assess whether or not there was anything that was anti-competitive, and they looked at our firewall and a number of our programs. And at the end of the review, they determined that there were no anti-competitive findings, and that's in the closing letter. There was, however, a legacy issue around a company that we had acquired and some information that they had inaccurately placed on Plan Finder, and so we had a consent order around that, but there was nothing related to any anti-competitive activity.
And finally, Ms. Ponce, are you familiar with a 2011 Visante study that found PBMs will save plan sponsors and consumers almost $2 trillion, or nearly 35%, between 2012 and 2021 when compared with prescription drug expenditures made without pharmacy benefit management? Can you speak a little bit about that?
Yeah, and I've seen that study as well, and I would even say more practically day in, day out, with the thousands of clients that we negotiate with, they've got very specific targets for us in terms of what we're going to do for savings for them in terms of generics and preferred brands, and so we have to live up to those commitments every day.
Thank you, and I thank you, Mr. Chairman, for the indulgence. I would just finally say that one issue which is obviously not before this committee is the power and ability of pharmaceutical companies to really skew the marketplace with very little controls on their ability to increase drug prices. And, you know, that's an issue which I think is very much part of this conversation and hard to disaggregate. But it seems to me that the ability to at least have some bargaining power against these pharmaceutical companies in the marketplace is something that we should attempt to preserve as much as we can. And with that, I yield back.
Agreed. Chair recognizes Mr. Collins from Georgia.
Thank you, Mr. Chairman. You know, sometimes I think when I fly in here, I've made this statement to my district before, that we fly into a wonderland of where reality doesn't matter anymore. Case in point, many of the things that I've heard this afternoon give me cause to believe, yes, we're there again. And this is an issue of community and independent pharmacies that play a critical role in my district in rural northeast Georgia. Mr. Chairman, with unanimous consent to enter into the record a report from the association representing senior care pharmacies on MAC pricing data, a letter from Blue Cross Blue Shield on compounding pharmacies, and several statements and examples of PBM interactions from community pharmacies.
Without objection, so ordered.
Look, I appreciate our witnesses being here. I appreciate the honest, the chance to have a discussion, but to be truthful, I'm very discouraging by what I see in the pharmacy landscape. Ms. Bricker, you stated in your testimony, PBM marketplace is extremely competitive. That's an interesting statement, since three companies, Express Scripts, CVS Health, and Optimum RX, control about 80% of the PBM market, which translates into 180 million lives. Not a great deal of competitiveness there. Mr. Arthur knows too well, community pharmacies routinely incur losses of approximately $100 or more on many prescriptions because PBMs or insurance middlemen reimburse pharmacies well below their cost to acquire and dispense generic prescription drugs that have skyrocketed in price. This is one of the most pressing areas that I believe demands congressional action. PBMs can wait weeks a month to update reimbursement benchmarks they use to compensate pharmacies while drug prices increase virtually overnight. That's why I introduced H.R. 244, dealing with this issue of transparency, and would encourage folks to be a part of that. Now, one of the things that's been interesting to me today is discussing mail order. Since PBMs own their own mail order pharmacies, I've seen information leading me to believe that a real incentive exists for them to steer patients toward mail order delivery. In fact, I've seen firsthand a fax received from a community pharmacist from Optimum RX indicating that he could not mail patients their prescriptions. Less than a month later, a patient gave that pharmacist a letter mailed to them from Optimum RX touting savings they could see if they got their prescriptions mailed from the PBM mail order pharmacy. While the letter states the patient is free to continue using a retail pharmacy, how sweet. It requires notification to an insurance company, and it is likely that many patients won't have time or knowledge to know that the mail order is not mandatory. This is extremely concerning from an anti-competitive standpoint and a patient care perspective. Mr. Chairman, I ask unanimous consent that both these documents be made part of the record. Mr. Chairman, unanimous consent to make these part of the record.
So admitted.
All right. And given that CMS has also recently finalized Medicare Part D requirement that allows PBMs to automatically auto-ship new prescriptions without express beneficiary consent, this is of particular concern, and especially to one certain gentleman that happens to be very close to me, and that is my father. Mr. Arthur, can you share your experiences regarding PBMs urging mail order delivery of medications over filling them in the store? How has this affected your pharmacies and other pharmacies? And regardless of your views about PBM and their practices, why should we be concerned? And if you can narrow that down.
I'll take your last question first, if I may. And I think Chairman Conyers mentioned it was back in the early 2000s, Campbell Conyers, which attempted to provide a limited antitrust exemption for independent community pharmacy. I can assure you the circumstances in the marketplace have deteriorated dramatically since that time. So this is a very pressing issue, and I think, it's interesting, we spent a lot of time this afternoon, talking about one of the primary goals being to drive generic utilization. It's interesting to note that the generic utilization rate in independent community pharmacy far exceeds that in mail order or any other sector. So,
well, thank you, Mr. Arthur. I appreciate that.
Thank you, sir.
I want to turn to Ms. Bricker, and you have talked about in Ms. Pons as well. You talked about teams of people that look at your MAC list, your transparency list, teams of people that do this. I want to give you a couple of examples on how you actually look at this, and you said within your 7 days. If a pharmacy, this is a recent example released from Alvera, it says, if a pharmacy filled a prescription of omeprazole, a common antipsychotic, on April 16, 2014, Express Scripts reimbursed that pharmacy $1.20. If the pharmacy filled the same prescription the next day, the 17th, it reimbursed only 20 cents. On the 18th, you paid another amount, this time 80 cents. Another one was potassium chloride, 45 cents on the 22nd of April, 26th of April, 33%, and on April 28th, 52 cents. One, I just have a direct question. Ms. Brigger, do y'all have two sets of MAC lists? Is there two sets of lists out there? Do you have two lists for MAC pricing?
We have multiple MAC lists, yes.
Okay, what about you, Ms. Pons?
Yes.
Okay. Is that just to keep the ball from being hidden from
No,
community farmers?
we have multiple clients. We
Oh,
have
multiple
thousands of
clients, okay.
and
So you prefer ones over the others?
we make
Never
sure our
mind.
client lists match what our,
The issue that I have, and I appreciate that, and the question is answered. I hear from pharmacies in my community that reimbursement under MAC appears to be arbitrary and has little connection to actual price. These examples seem to indicate that. Can you please explain the disparities in MAC pricing you pay to these long-term care pharmacies? Ms. Bricker?
So I don't actually know the acquisition cost of any given pharmacy. Our policy is to survey the market based on a number of price points that are available, both confidentially to Express Scripts as well as publicly, and in an attempt to respond in kind to the market. And so we make every effort to ensure that we're reimbursing a fair amount for prescription drugs from a generic perspective. We have an appeals process that if we get it wrong, a pharmacy can file an appeal and provide us additional evidence.
Ms. Bricker, have you ever told a pharmacy that if they appeal any more that they would be cut off from their plan?
No, I have not.
Not you personally, your company.
I am not aware of us ever making that statement, no.
Ms. Pons?
I'm not aware either.
Will you answer the question long-term that I asked to Ms. Bricker as well on MAC pricing disparities?
Yeah, I actually have a very similar answer to hers in the sense that we do our best to try to estimate what we think people are buying at and put a reasonable margin on that because we want them to dispense generics.
Okay, so would you find it, if I told you that I know of pharmacies who have been told, if you appeal, we will deal with it in your contract, you cannot appeal this, would y'all both find that egregiously appalling?
I am not aware of Express Scripts ever making a statement like that.
Not what I asked. I said, but if they were told that, a pharmacy was told that, would you find that appalling that your companies would say that?
Yes, I actually would agree with you. The appeals process is there to ensure that we are responsive to the market.
Well, I think there's a concern because there is a disconnect because this is what's being told. I think the concern that I have here is all in all in this playing field, there needs to be a level playing field. There needs to be a playing field for community and independent pharmacies as well as the other companies involved in this market. Right now, that's not. And you can talk about it all you want. We can go into different pricing. We've already talked about multiple lists, and we talk about the appeals process, and we also know from pharmacists who have been told if you appeal more, we'll cut you off. What is even more appalling to me is when my local pharmacists across this country try to speak out about this, they receive letters and discussions from PBM saying, if you make too much noise about this, your contract could be in jeopardy. That is not right. I will continue to fight this, and if you don't believe that it's true, it is true. And when we understand this, here's my concern, that in the coming future, because I hear from my pharmacists all across this country and in Northeast Georgia, if it continues the way it is, they will be closing, and all those wonderful savings that are being donated from PBMs are going to be lost in closed businesses and closed lives. And I just have a question. Who will my folks in the 9th District of Georgia call when they need someone at night and their local pharmacist is the one they trust? Ms. Bricker, they're not going to call you. They're not going to find you in St. Louis. They're not going to find you, Ms. Pons. They're going to try and find their local pharmacist who has been closed because of the anti-competitive nature of this field. This needs to be addressed. With that, Mr. Chairman, I yield back.
Chair recognizes the gentleman from California, Mr. Issa.
Okay. Well, I'm going to start off, Mr. Alto. In your statement, it's already been read a couple times, but I'll grab a couple of the key words you used. This is the PBMs are the least regulated sector of health care. I guess without the FDA, they might be. Essential elements of competition are not there. The following are transparency, choice, and lack of conflict of interest, right? Okay, well, and by the way, I'm not trying to make anybody a good guy or a bad guy. I just like to put this portion of the market in perspective, and I think sort of as the witness against the PBM sitting between these two fine women from the industry, you're the one to ask. If I told you that from the 10-Ks published for the two public companies on each side of you, that, for example, Express, and of course they've got mergers, there's other factors, but their annual reports, Express Scripts went from about $42 billion in 2010 to $100 billion in gross revenues. Their profit, gross profit, went from $2 billion to $3 billion during that period. After-tax revenue went from $1.2 billion to $2 billion during that period of time. On the other side, CVS, a bigger company, getting bigger, and in the retail space, so it's a little more complex to follow them, went from $97 billion to $139 billion. They went from $6 billion in profit to $9 billion in profit. And they both went up slightly in their per share. Let me ask you a question. If somebody sells, for example, $100 billion worth of product and makes $2 billion after expenses and taxes, just one question, where do you think those excess profits are that you say are there?
Well, first of all, Congressman, what we're looking at are entities that are moving information and are moving...
But I'm asking a question to you that is narrow, and I want to make sure that I don't get I don't know, you had an opening statement, so please stick to the question, because I'm going to ask the others question.
I wanted to explain it.
If a company makes, if you're qualified to answer on the financial part, if you sell $100 billion and you make $2 billion, and I checked, and they've had the same chairman for a long time, and he gets decent compensation, but it's in the millions, not the billions. So from a material standpoint, they don't have but 2% of gross sales in profit. Now, unless there's money hidden under a mattress, my question for you, and I'll use Express Scripts. I could use either, but your Express Scripts is a much simpler company. They're basically a wholesaler middleman. They drive down their cost of distribution, particularly their mail order process. They negotiate the lowest prices they can. They squeeze, if you will, the retailer on one end as much as they can, Pfizer and the other pharmaceuticals on the other, and they end up with, $1.50 a share for their stockholders, or about $2 billion, and it hasn't gone up or down in a major percentage. So my question to you is it the lack of, as you said, the lack of transparency and competition, is that really at any of these pharmaceutical companies? And I realize there's a difference in, if Ms. Bricker's company makes $2 billion, it might drive Mr. Arthur's company out of business because of their ability to buy and so on. There's no question we could have a discussion between retail and wholesale and their tactics, and of course with CVS, an integrated company that has both. And I'd like to give you a chance to answer that if you'd like to throughout the hearing. But the real question is, where are these excess profits that you're alleging? If I go to Pfizer or any number of other large, successful pharmaceutical companies, I will find after-tax revenues in as much as double-digit of their gross sales. So my question to you is, where is the evidence of that? Quickly, and then I'd like the others to answer, because I'd like to understand that part, which I think for this committee, looking at competition and whether they need to be regulated, this is a big question.
Sure, and I'd like to respond to you in writing because it's a complicated question.
Okay.
But in my testimony, looking at just their margins have increased substantially. But let me answer you more carefully in writing about what the answer is.
And for the two wholesale pharmacies, and I'd like to also include the retail quickly, if there were more transparency and a more level pricing for what a particular pill or tube cost, and instead of a complex set of rebates and negotiations, if we look to these monopolies, particularly people who have an exclusive, and said, look, we don't care what you sell it for and how much, but you can't be all over the place on prices such that these MACs are so different, would that really affect your business model in an adverse way? I know, quickly, for Mr. Arthur, he would love to see a price where the price is the price to a certain extent, and only discounts are truly based on volume, the truck delivery versus the UPS delivery, because that certainly would change these disparities that are driving retail out. Quickly, I apologize, Mr. Chairman, if they could answer.
Yeah, so scale matters. And, you know, in a free market where you're able to buy in a larger quantity, we've seen this not just in pharmacy, but in other aspects of in other industries. And so, yes, it would be absolutely detrimental to our plan sponsors to have fixed pricing, if you will. But with that said,
Actually, it was cost basis from a monopoly, more like a public utility. You can buy your electricity cheaper from an exclusive source that has to sell it to you if you're a volume user, but the difference is based on actual earned discounts. But go ahead, please.
yeah, but our MAC is responsive to that very thing. I understand, you know, when I'm establishing MAC, that I'm not going to establish MAC for an independent pharmacy the same as that of a large retailer that can purchase the product at, you know, a much more deeply discounted rate. And so it's our attempt to do that. Our plan sponsors, you know, count on us to keep costs down, and we have guarantees in our contracts. We are obligated to ensure that we're lowering costs year over year for our plan sponsors.
Right. In your case, your MAC price is always higher than your cost, I assume.
I'm sorry?
The pricing you're willing to pay the retailer is always higher than your actual cost.
Well, I couldn't say that with 100% certainty. That's definitely my intent. My intent is to...
Well, you know your cost, don't you?
You're saying my cost at mail?
Well, you buy. You're a large buyer. He's a small buyer.
Yes, sir.
You set his price based on an assumption of what he paid for the product. I just want to understand, can you say here today, under oath, both of you, that you always provide the retailer a, quote, price that is at least above what the two largest people in the pond pay?
Absolutely, 100%.
Okay, so you can certify that. You can too.
Yes, that we make every effort to do that, yes.
Well, every effort. You've got great computers.
No.
Would you say with the certainty of somebody gets fired if that's not the case, if you actually expect the small retailer to take less than in fact you're already paying?
Yeah, what I can tell you is that our independent pharmacy community gets paid a higher rate of reimbursement on generic products than our own pharmacies do. And the other thing I would just add to the mix as well, because we haven't talked about this, is the fact that there are a number of very large, what are called PSAOs, Pharmacy Service Administrative Organizations, that independents belong to. I believe over 80% of the independent pharmacies join one of these big 3 Fortune 50 companies, and there's some large independent PSAOs as well. Those are the actual entities that we're negotiating with. We're not negotiating with, you know, typically, you know, a small, single, independent pharmacy. And so there is a lot of back and forth. And to the extent that we can't make changes sometimes, it's because we've got a contract that's 100 pages long with our client that says everything under the sun that they want in their network. So we're not truly trying to make people's lives difficult.
No, I know you're not. And Mr. Chairman, I know that I'm actually stealing from your time every minute that this goes on. But I would ask that Mr. Arthur give his opinion on this, because I do think that, and I said this to 2 of the witnesses when I met with them in advance, you know, the hotel industry and the airplane industry used to suffer from the fact that 2 people on an airplane sitting next to each other, one could pay 4 times more than the one next to them, and it was always very hard to understand. At least now, if you go to an online website, you can at least get some transparency on what the best deal is. And I think for the retail industry, this is part of what's not existing in healthcare, and I'd just like Mr. Arthur to give his insight on not knowing what something gets bought for by anybody except what you get told on reimbursement. I will owe you, Mr. Chairman.
Very briefly, Mr. Congressman, one important distinction. You mentioned the role of the PBMs as a wholesaler, though. The PBM stocks no product in inventory, doesn't handle any product in inventory.
I apologize. I called him a middleman, but you're right. Except for their own mail order, they're working with you based on your inventory.
Yes, sir. And the reason I mention that is when you give the numbers, the genesis of the PBM industry was due to their technical expertise at moving from a paper environment to an electronic environment for the processing of claims. We could have a discussion today, a very vibrant discussion about the other services that they do provide in that space. But essentially, they are negotiating those prices for purely an administrative function, in my view.
Thank you very much, Mr. Chairman, and I will owe you that large poker chip.
Thank you. I have about 30, 40 minutes of questions, but I know I'm limited to several minutes. Mr. Balto, aren't we talking about, and I like Mr. Ice's line of questioning concerning excess profits, but I'm a capitalist. And are we really talking about excess profits or market shares?
Well, look, I think the PBMs, there is a service that the PBMs perform, and the question is, is the market acting competitively? Is their ability to lower prices being fully translated in lower prices to consumers? And we see these trends which the ranking member identified, which the Consumers Union statement identified, that shows that with higher drug prices that their profits are going up.
Okay, let's set aside antitrust issues for a moment, though. But isn't it just customary, usually, those that have a larger share of the market generate more profits?
If the market is behaving competitively, you would expect price to be competed down to marginal cost. You wouldn't expect to see their profits per script increasing in this fashion, or their profits increasing overall in this fashion.
Okay, let's move to, and I know what Mr. Arthur's answer is going to be on this, so I would like you to answer it, then I ask Ms. Bricker and Ms. Pons to give me their opinion of this. What is the downside of independents coming together and buying prescription drugs in bulk? What's the downside of that? If there is an exemption to the antitrust law for pharmaceuticals, what is the downside of independents getting together and purchasing drugs?
There's no downside, and somehow in 19 pages of testimony, I did not deal with the collective negotiation point. I apologize.
Well, no, let's not talk about the antitrust part of it. That's another hurdle.
There's clearly a significant advantage to pharmacies coming together. There's antitrust uncertainty, and antitrust exemption would be appropriate. My colleagues on the panel tell you about PSAOs. Those PSAOs are ineffective. In fact, PSAOs are often prohibited by the PBMs of even turning over the contracts to individual pharmacies. There needs to be greater ability of people like Mr. Arthur to collectively negotiate to protect their interests.
Ms. Berger.
A couple of things come to mind. So pharmacies absolutely can join group purchasing organizations and collectively buy drugs. Or they can also join PSAOs to have them represent them in negotiations with PBMs. In our contracts at Express Scripts, it's explicitly written, to Mr. Balto's statement that we prohibit member pharmacies from seeing contract. It's required that the PSAO pass the contract that they have executed on behalf of a member pharmacy to that pharmacy. And so it's important to us to have independent pharmacies in network. We have 25,000 independent pharmacies in network. Just to give context, less than 5% of independent pharmacies service a rural area in the United States. These are still very vital. It's very important that those pharmacies stay in business, but they command a premium, as they should, because they're serving a population that no one else is.
Ms. Pons, would you care?
My comments will be similar to Amy's in the sense that we welcome pharmacies to join PSAOs. It helps us, obviously, to negotiate with 5 PSAOs as opposed to 20,000 individual pharmacies, and those PSAOs are able to negotiate very effectively on behalf of their clients. And similarly, we require that the PSAO share that contract back with the pharmacy, and the pharmacy actually has to tell us in writing that they've designated the PSAO to be their agent for the negotiations.
Why the disparity then in pricing? Because of volume? Is there a disparity in pricing with independents, with some entity representing them, negotiating prices with pharmaceuticals compared to your companies?
Yeah, we don't know, the price that others pay. I would just say that.
Well, we do know that independents pay significantly more across the board than examples of your companies. Why?
I was going to say they're taking their volume through their PSAO to try to get the best deal that they can. That is not going to be the same as a Walgreens who has a much greater footprint. But as stated earlier in the testimony, we do factor that into the reimbursement that we provide to our independents. And again, they receive a richer reimbursement for their generics to take that into account.
Mr. Arthur, I live in a rural area. We have independents, and we have CVS and other pharmaceuticals, pharmacies. What do you offer to your customers that you do not see the big chains offering, particularly if it's through the mail?
Well, there's a whole host of services that we're offering in a very personalized way, from comprehensive pharmacists, clinical services, immunizations, consultations, medication reconciliation. There's a whole host of services that are being provided, and the reason why the independents, in my view, are more successful is based on the relationships that we've developed in our communities over a great period of time.
Again, this is for Ms. Pons excuse me, no, this is for Mr. Balto. Mr. Balto, where do you see the transparency line concerning what companies, larger companies, or any company for that matter, have to divulge? Who draws that line? Where is that line?
Well, what you said, by the way, just to supplement Mr. Arthur's comment about the services, one critical issue.
You aren't dodging my question, now,
yeah,
are you?
I was trying not to.
Okay. I was a prosecutor, so it's not going to work.
It didn't work. In terms of the transparency line, I think we should listen to what the market, what's going on in the market. This Department of Labor proceeding that the ranking member mentioned before the ERISA subcommittee, unions and major employers and consumer groups all talked about the kind of transparency was necessary for a plan sponsor to fulfill his fiduciary duty to make sure he was receiving the plan was receiving the benefit of the bargain, and that requires very robust disclosure of the rebates that the PBMs are receiving from the pharmaceutical manufacturers, and then the plan sponsor, armed with that information, can make sure that they're receiving the best deal in their arrangement with the PBM.
Okay. If I'm buying something from somebody's selling antique cars, and I buy antique cars, why would I divulge? Why would I think of divulging what the person selling the antique car is going to sell it to me for compared to someone else who wants that same car?
So for me as a plan, an employer or a union, what I'm purchasing in part is their ability to negotiate rebates. And so I want to know how they're doing at that specifically for those, for the manufacturers. And then look, drug by drug, over time, and see how effective they're being at that. And in that way, I can figure out whether or not I'm getting the benefit of the bargain, whether those rebates are helping to lower my pharmaceutical costs.
Ms. Pons and Ms. Bricker, I don't think I gave you the opportunity, although you're probably glad I passed you on it, on the issue of the downside of independence collectively purchasing. Now, there was some discussion about they're able to join groups to do that, but the numbers don't seem to be indicating that there is fairness or a level playing field there. Could you expand on your answers there a little bit, Ms. Pond? Do you know you get my question?
I guess what I would say is that we welcome anybody that's part of this value chain in helping reduce costs, provide access, and improve health outcomes to the extent that they can be more efficient, just like we're trying to be more efficient in our PBM and in our pharmacies. We would welcome them to be able to do that because that's going to ultimately help our clients and help our patients that we're all trying to serve.
And Ms. Bricker, I'm assuming you would agree with that. Do you want to add something to it?
At Express Scripts, our mission is to make drugs safer and more affordable. And we welcome, in working with you, to have a robust dialogue about the entire supply chain, from manufacturer to patient. And today we're focused on, a couple of areas of the supply chain, but we think there's actually an opportunity for us to work with wholesalers, with manufacturers, with PSAOs, with all of the constituents within the supply chain to continue to lower costs for plan sponsors and patients.
But do you see, and I'll get back to you on that, do you see independents eventually going out of business because of the volume that your companies are able to sell and able to keep the price lower than what a pharmacy can? Do you give me your opinion on what you see 5 years from now or 10 years from now for independent pharmacies?
We believe that independent pharmacy is viable. We believe that, and we're seeing it in the data. If history is, any indicator of the future, then no, this industry is quite robust. There are 68,000 pharmacies. That's up from the prior year. NCPA's own data suggests that independent pharmacies are remaining steady and constant. And so, no, I believe that it's a viable business and one that students coming out of pharmacy schools are entering the business of opening retail pharmacies today because it actually will pay the bills and it's a wonderful career.
Okay. Ms. Pons?
Yeah, no, I agree with that, and independents are a cornerstone of our networks. We don't have any networks that don't include independents. They're important to our clients to have that access. So, and as Ms. Bricker pointed out, the number has held steady with well over 20,000 in the country.
I have a dog in this hunt, and I've experienced this several times. My daughter has cystic fibrosis. So there are dozens of drugs that she takes. Sometimes the prices go up, sometimes the prices go down. But what I find very, very important is the one-to-one, face-to-face communication with a pharmacist. And believe me, on more than one occasion, our pharmacists here, and even when we were traveling in England where we ran into a problem, they were able to communicate. What can you offer? Can you offer that same thing, that same service that the independents offer?
I would say we certainly do our best within our own pharmacy channels, to whether it's our retail pharmacies or our specialty pharmacies, and particularly our specialty pharmacies that work with patients that have chronic serious conditions where they have expertise in particular disease states that a lot of normal pharmacists don't, and they do develop very close relationships with those patients and their caregivers.
I'm going to wrap up here quickly, but I just want to give each of you 15, 20 seconds to give a closing statement. So, Mr. Balto, you had your hand up, please.
Sure. First of all, these firms own their own mail order and specialty pharmacies. It's in their incentive to drive consumers away from these community pharmacies that they want into their own pharmacies where they can maximize their profits. And especially for people who need specialty drugs like your daughter, that's a real critical concern, especially when specialty drug spend is increasing so dramatically. And that's why this committee needs to look at the restricted networks these PBMs use.
Ms. Bricker?
At Express Scripts, we're committed to making prescriptions safer and more affordable. We stand ready to assist our plan sponsors and their patients in looking into the future to understand where drug pricing is going in an attempt to partner with them in innovative ways to make prescription drugs safe, affordable, and accessible. Thank you for the opportunity.
Ms. Pons?
Yes, and I would just continue to reiterate the importance of independent pharmacies to our company, and would note that in our preferred Medicare pharmacy networks, over 40% of the participants are independent pharmacies. They're critical to helping us deliver a service to our Medicare population. Thank you for having us.
You're welcome. Mr. Arthur?
Mr. Chairman, thank you. As I sit here, if memory serves me correctly, I look up at the wall and I think that's former Congressman Jack Brooks. on the left there, and going back for over 25 years, we have been fighting for equality in the marketplace, using the antitrust law to examine the antitrust law to seek fairness. We have survived by evolving. My independent pharmacy is half the size. I employ half the people I did 20 years ago. I think it's really telling that in this environment, and the reason I mention that is you asked the question, what's the harm in allowing the pharmacies to do that? Pharmacy has attempted to meet every challenge. We have attempted to get together to be able to purchase effectively, but when we are successful in doing that, if we run into challenges with the MAC, with the timely updates of MAC, it's interesting to note that, you know, we've heard today about compliance with timely updates, and I'm sure there are very robust departments within these large corporations. Why is it that in 2 states they have fought vigorously to repeal efforts to timely implement MAC updates? We in pharmacy will continue, in independent community pharmacy, continue to find ways to survive and be able to provide the types of services that you alluded to the people that depend on us in our communities.
Thank you. Mr. Johnson and I were having a discussion really before the hearing began, and the two of us, most of the time we see eye to eye because we are looking for information, right, Hank? That's right. We're looking to be educated, and we in Congress, we don't have all the answers. You know, when we get elected, we think we're taller, smarter, and better looking right away. But we look to you people, experts in your area, of how to make this, how to improve the quality of life for all Americans. And I think each of you have a role to play in that. So my friend Mr. Johnson and I, we're looking forward to hearing from you on how we can, for the lack of a better term, I'm not even going to use the term, how we can improve the quality of life for all Americans. So that is my request, our request of you. So please participate in this with us, send us information, give us your ideas so we can accomplish that. And I want to thank everyone. This concludes today's hearing. Thanks to all the witnesses for attending. Without objection, all members will have 5 legislative days to submit additional written questions for the witnesses or additional materials for the record. The hearing is adjourned.
Good job.